Welcome everybody to our first Pediatric Grand Rounds of the new year. Happy New Year to everybody. We apologize for the delay. Technical difficulties got the best of us this morning, but we are ready to give you an amazing presentation this morning, which I think will be relevant to many of your practices. We have two of our experts here in colorectal motility, and we are just really privileged to have them both come and speak with us this morning. So Dr. Kelly Austin from Pediatric Surgery and Dr. Vibha Sood, who direct the program, are here to give us look into their field and get us up to date on all of the great work that they're doing. So with no further ado, Drs. Austin and Sood.
Thank you very much. Hey, we're really excited to be here today. I'm so sorry for the technical difficulties, but I hope you still have a lot of time to take home some good points. So we're just going to jump into our objectives, which are essentially, I would hope that in this hour, you'll be able to recognize the morbidity of chronic constipation and the burden it causes patients, families, and the healthcare system. And also, I'm hoping that you can identify goals of collaborative approach to the colonic rehabilitation. And during this whole talk, I think it's really important we're going to stress rehabilitation. I think that's about return to normal for our patients with chronic constipation. And also, I'm hoping that by the end of this talk, you'll be able to identify patients that would benefit from referral to the bowel management program and our collaborative program. And finally, I anticipate that you'll be able to recognize the role of both motility evaluation and surgical intervention for those refractory patients with functional constipation. So first of all, what's the problem? What's the big issue? And significantly, it's essentially refractory constipation or constipation in children. And obviously, it's an incredibly common but expensive problem. The prevalence is reported at somewhere between 3 and 17% in the United States, with making a significant impact in the healthcare cost, with over 25% of referrals to GI doctors being related to constipation. It's been reported as roughly historically like 3.9 billion a year in direct medical costs. This is a little bit older data now that I'm sure is significantly higher. And even more importantly, probably is the impact that it makes to children and their families' quality of life. So a significant portion of these costs are contributed to, or are attributable, excuse me, to the ER visit cost. And there have been studies that have shown that these ER visits are increasing in numbers, doubled in roughly by 50-some% in just 5 short years between 2006 and 2011, and the aggregate national cost has increased by 121% with patients with the diagnosis of constipation in ED. The following tablet, I know it's hard to see, but it was data taken from the Pediatric Health Information System, where number of patients seen predominantly through 2015 to October 2015 to September 2016, just 1 year at participating institutions was gathered. And Children's Hospital of Pittsburgh, for example, cost at that time saw 1,474 patients in this 1 year time, with basically charging up to almost $3 million in charges. And the average cost per patient was $2,000 per visit. So, you know, this intractable constipation is the real problem. And basically, while constipation is common, those patients that persist are still significant. And these are patients who are unresponsive to standard therapy. And it's associated with a difficult passage of stool, but also painful bowel movements, abdominal pain, hemorrhoids, prolapse, and ultimately leading to megarectums, potentially insensitivity to urge to pass, stooling, and caprices or accidents. And what's even almost, if that weren't enough, many children suffer from bowel and bladder dysfunction, and they can have an increased urologic morbidity with increased fecal load, causing a mechanical compression of the bladder, affecting the neuropathways to the bowel and bladder, ultimately causing potentially urge to incontinence, frequency, decreased emptying, bladder spasms, high post-void residuals, and maybe contributing to vesicoureteral reflux and even your recurrent urinary tract infections, which can ultimately, potentially in the worst scenario, lead to renal scarring and kidney failure. But one of the significant problems and the devastating effect of fecal incontinence is basically the impact it makes on quality of life. And this quality of life gets greater, this negative impact to the quality of life is greater as children get older, and the longer, obviously, it's affecting them. And it's imperative that defecation disorders are addressed proactively to prevent this horrible potential morbidity. So to understand the real kind of problem, I mean, to know how to fix the problem, we need to talk about the basics.
So that's where I come in. So when we're talking about bowel movement basics, so we know everyone poops. While everyone poops, not all poop is the same. And especially more so, it's very relevant for human poops. As we know, for some of us who've taken care of these patients, these human poops can come in different shapes, sizes, and consistencies. Multiple factors influence the bowel movements, such as nutrition, our gut microbiome, the motility of the colon, the functions of the anal sphincter and the pelvic floor muscles, our enteric nervous system. Normal bowel function basically constitutes the function of the colon, rectum, as well as the anal canal. Normal colonic function is characterized by presence of high amplitude propagating contractions, which defines the normal colonic motility. Rectum, on the other hand, is a storage reservoir, which allows for the awareness of the rectal filling as well as the urge to defecate. Anal canal controls the defecation as well as is responsible for maintaining the continence, and which is usually conducted by the anal sphincter complex. Colonic motor activity basically consists of two portions: segmental contractions and propagated contractions. Segmental contractions are single phasic contractions, which constitutes most of the colonic activity. The function of these segmental contractions is to slow down the colonic transit to allow for optimal absorption of the contents as well as the propulsion of the fecal matter. Propagated contractions are predominantly two types. One is called as high amplitude propagated contractions, and we'll be talking a little bit more about that during the later part of this talk, and a periodic rectal motor activity. To do a visual depiction of a high amplitude propagated contraction, as the name suggests, these are high amplitude migrating contractions, which are predominantly responsible for transportation of the colonic contents over the large portion of the colon. They generally occur about 4 to 10 times per day, mostly after meals, upon awakening, preceding defecation. When we talk about periodic rectal motor activity, this is a unique motility pattern of the rectum, which is triggered by the presence of stool or gas in the rectum. It usually occurs mostly during the nighttime. This periodic rectal motor activity is an intrinsic braking mechanism, which is helpful in preventing untimely flow of the colonic contents, particularly during sleep. So what about the defecation dynamics? What constitutes a normal defecation dynamic? So normal defecation dynamics is regulated primarily by three major muscles, namely internal anal sphincter, external anal sphincter, and puborectalis muscles. These are the three major muscles. Of course, there are multiple other muscles groups in the pelvic floor, but these are the three major components that we're going to talk about. Internal anal sphincter is primarily under autonomic control, which determines the baseline resting tone of the rectum or the anal canal. And external anal sphincter and the puborectalis muscles are predominantly responsible for maintaining the continence. So defecation is basically deferred with voluntary contraction of the external anal sphincter and puborectalis muscle. So what happens during a normal defecation process? Stool or fecal matter comes from higher up on the colon, which results in sensory perception of stool in the rectum, leading to rectal distension, which is further followed by relaxation of the internal anal sphincter, as well as the external anal sphincter and puborectalis muscle. And this, along with the contractions of the abdominal muscles, as well as the colonic and the rectal contraction, results in expulsion of the fecal matter. So we talked about normal defecation dynamics. So what is abnormal defecation dynamics? Abnormal defecation dynamics are two different kinds. One is a dysenergic defecation, and another one is a fecal incontinence. Dysenergic defecation is an acquired defecation disorder, which results due to inability of the abdominal, rectoanal, and pelvic floor muscle coordination, which results in abnormal defecation. Fecal incontinence, on the other hand, is a defecation disorder, which results in leakage of the stool, which can happen either due to damage to the anal sphincter muscle complex or due to pelvic floor muscle dysfunction. And most commonly in children, we see this because of the impacted stools in the rectum, resulting in overflowing continence. So functional constipation in children can typically be traced during 3 stages of a child's life: during early infancy, with the introduction of solid foods, as well as with the toilet training period. So what happens with functional constipation? Presence of residual stools results in infrequent passage of big and hard feces, which can further cause fissures, bleeding, which results in painful bowel movement. And these painful bowel movements in children promotes stool withholding, painful defecation, further accumulation of the residual stools, and this further promotes rectal dilation, and which can often end up with megarectum in not all, but in worst case scenarios. We also know that fecal retention can result in soiling episodes, which is also called as encoparesis or overflow incontinence or fecal incontinence. And this can happen multiple times during the day. We also know that encoparesis and constipation is also associated with urinary incontinence, which can present during the daytime as well as during the nighttime. And we know with our experience, many a times fecal incontinence is often accompanied with urinary incontinence. In terms of long-term prognosis for functional constipation in children, based on a study of children referred to pediatric gastroenterologists, about 50% of the children recovered without laxatives within 6 to 12 months. 10% were doing well while taking laxatives. However, 40% of the children still remain symptomatic despite the usage of laxatives. However, over the time frame of 5 to 10 years, 50% of the children recovered with no longer taking laxatives, and almost 80% recovered after 10 years with no longer taking laxatives. Younger age of onset, longer duration of symptoms, and delay in the medical treatment were some of the adverse factors affecting long-term prognosis. So I'm going to switch gears and talk about surgical aspects of the colorectal disease.
Yeah, so in order for patients to have normal function, they have to have typically normal anatomy. And this is where a lot of us as surgeons get involved with children who are born with some component of abnormal, either anatomic as far as muscular development or caudal regression, or neurologic innervation, abnormal neurologic innervation to their bowel. And the most common things that we see as surgeons are patients who have anorectal malformations, which make up a broad complexity of abnormalities because they often have other associated anomalies such as spinal abnormalities or sacral or bony abnormalities. There's also Hirschsprung's disease, which is congenital intestinal ganglionosis, and it can be complicated by an association with a certain number of patients with Down syndrome. And also what seems more obvious perhaps is neurologic abnormalities, both acquired and congenital, that are more permanent, such as spina bifida, spinal cord injury. And then we get also involved with patients who've had teratomas or some type of pelvic tumors that need resection that influence their either innervation or muscularity to have normal bowel function. So I'm going to quickly go on to what an anorectal malformation is. And obviously this is a patient that has no opening at the normal anal orifice. And they may have associated urologic, gynecologic, or sacral abnormalities like we discussed. And one of the things, and they could be a spectrum, and one of the things that's most important perhaps is, I'm showing a quick little video here of a male patient that has an anorectal malformation, and it can be something as minor as a perineal fistula, where the anus didn't make it right down through the sphincter complex, or a higher injury, yeah, thank you, a higher connection to the urologic system, such as the prostatic urethra or even the bladder neck. And as you see here, as we're going up with the higher connections to the bladder or the urinary system, there's less development to the musculature and maybe more abnormalities with the sacrum. So traditionally, we like to describe these as either a higher imperforate anus or a lower one, but if we just go anatomically, that helps us with prognosis. So the goal of surgery is obviously to reposition the rectum and the anus into a normal location anatomically and to minimize surrounding anatomic structures. But we know that unfortunately, it's just not one and done. Even the best operation in the best technical hands isn't give the patient necessarily the best function if they have minimal development. So that's very important. They need long-term follow-up in a colorectal center. And getting back to the nervous system and the colon, clearly the loss of normal function also affects their ability to evacuate stool, and they might lose muscle strength of their abdominal wall, or they might just have poor innervation to their GI tract. And the treatment in these patients, it's usually lifelong to achieve social continence and to improve independence and autonomy. One of the more unique abnormalities is the enteric nervous system is the congenital intestinal gangliosis, or known as Hirschsprung's. And our enteric nervous system develops typically from head to toe in gestation. And ultimately, a certain number of patients, and this can be discovered by looking at a biopsy that shows these ganglion cells or normal innervation within the wall of the GI tract. And when you're missing that, it's roughly 1 in 5,000 children born with this abnormality will have the absence of ganglion cells, and most commonly the distal bowel. And this leads to tonic contraction, inadequate peristalsis, enlargement of the proximal segment, and ultimately complete bowel obstruction and perhaps even enterocolitis. Then there are still patients that somehow make it through to limp along with partial obstructive-like symptoms and chronic constipation. And these are patients that we even see even in younger children, or even at 10-year-olds. Most recently, I took care of a patient like that. So the diagnosis can be made here with often adjuncts such as contrast enemas and anal manometry, but it has to be confirmed by rectal biopsy. So what is the need? Hopefully you're starting to see the need for a colorectal center. And basically, historically, colorectal centers were started by pediatric surgeons who were dealing with these complicated anorectal malformation patients or Hirschsprung patients who also suffered from lifelong fecal incontinence or chronic constipation. And it soon became clear that these complicated patients need a multidisciplinary approach, and they started to use we started to acclimate multidisciplinary clinics, and ultimately patients with non-organic but with severe refractory constipation started being referred to pediatric surgery colorectal centers, and now in collaboration with the neurogastroenterologist, we were able to begin bowel management programs with children with these problems. And we know that obviously there's long-term morbidity and colonic damage if you don't become more prophylactic, and proper management will prevent long-term colonic dysfunction and also minimize the associated comorbidities when you're aware of these problems. And ultimately, it's cost saving to the healthcare system. So there's been multiple studies that have shown and documented the positive impact that a structured bowel management program can have on patients with severe functional constipation, and obviously patients who have severe constipation from surgical or anatomic reasons. These include decreased unplanned visits to the emergency room, reduced hospital admissions, decreased costs for the constipated-related healthcare, and just as importantly, if not more importantly, improved health-related quality of life and minimizing risk for bladder morbidity. Of these patients who participate in a structured bowel management program, long-term studies have shown roughly 75% remain adherent. So who are we? The Colorectal Center, we're a very large group, and I was unfortunately unable to put everybody involved in our center in these pictures, but we're several pediatric surgeons, nurse practitioners, PAs, and nurses from both the colorectal, the pediatric surgery division, and also the GI division, as well as our pediatric, adolescent, and gynecology and pediatric urology, neurosurgery, PM&R, pathology, interventional radiology, garden variety. I'm sorry to say it that way. I should say fluoroscopy, radiology, and we also use child life, nutrition, wound care, and behavioral health. Our goals, and I'm going to stress this again, is rehabilitation. It's and it's a personalized approach, and we're not just trying to make sure patients have a bowel movement daily. We're trying to really salvage the colon and get it back to normal so that they can reverse and minimize colonic damage. And a lot of our patients are starting off behind the 8 ball with these congenital anomalies. So, you know, it's even more important to maintain the quality and their care of their colon. So what we do is we have a multi-system approach, and I kind of touched on this briefly, that we're going to hit on, you know, optimize their nutrition, their pelvic floor physical therapy. They may need medical management, behavioral health and behavioral medicine, and motility studies, and ultimately very few patients really come back to formal surgical intervention after their initial repair. So a typical approach, a typical patient who was referred to us would you know, seek out our colorectal center, and our colorectal schedulers would call them. We would have a initial intake, and ultimately at that point gather information, gather any studies that they may have already had, and present them at a multidisciplinary patient care meeting, which we hold weekly. And then they will eventually come to our institution, and a bowel management workshop, which is an educational seminar, would be given to them, which is a 2-hour seminar. Then they come to clinic. And during this time, we then proceed with a very comprehensive evaluation. We review any of the testing, and we might actually order tests even that day, such as, or have coordinated a test that day, such as a contrast enema, or proceed with additional testing that we need. But we ultimately come up with some bowel management program that is unique to that individual. And we also will then have them also engage in these other multidisciplinary therapies, such as pelvic floor physical therapy. But probably the most important thing to making this all work is our close follow-up and support. And it is extremely important that that happens, and it's a matter of communication back and forth to make it right. So when we see patients with our problems, we really are looking at predictors of continence, and this influences our management. Patients with anorectal malformation, we have to look at whether they have a normal sacrum in addition to the type of malformation that they had, and whether they have any spinal tethering. Patients with Hirschsprung's disease that have already had surgery, we worry about whether they've had any sphincter damage with their previous operation, or how much colon do they have left, and what's their colonic motility like. And patients, or whether they have any ganglionosis still residual. Patients with neurologic bowel, we worry about, you know, just how much muscle or sphincter sensitivity they have, or ability to squeeze that they have. And patients with functional constipation, you know, again, we're really worried about their normal. Do they have normal anatomy, or are they just built as functional constipation, or are they really a more subtle problem? I'm going to turn over to Vibha to talk about our evaluation and treatment.
So when it comes to evaluation, we start down with the basics that we learned in our medical school. So I cannot re-emphasize the importance of good history in evaluating patients with constipation. It's very essential to ask questions about the onset of the constipation symptoms, stooling pattern, consistencies, frequencies, absence or presence of stooling accidents. It's also essential to talk about urinary symptoms, any past history of surgeries. For patients suspected for Hirschsprung's disease, we know we diagnose Hirschsprung's disease during early newborn period or early infancy. However, there has been some instances of patients being diagnosed with Hirschsprung's disease in late age. So it's also essential to take into consideration the passage of meconium. We also take into consideration the fact that when we are talking to patients about the stooling consistency and patterns, verbal description, of course, we use all kind of foods to have analogies to the type of stooling that our patients have. We have come up with a uniform system, what we call as a Bristol stool chart, which is very helpful for us to determine the kind of stooling pattern our patients have. Physical exam should involve a thorough and a detailed abdominal exam. In patients we are suspecting with any neurological abnormalities, a neurological exam should be conducted, especially when there is a suspicion for any tethering of the cord or any spinal cord abnormalities. We should definitely be taking a look for presence of sacral temporal, and we should also be checking for cremasteric reflex. And last but not the least, the importance of digital rectal exam in any patient presenting with constipation symptoms. And the next slide is going to talk about the importance of digital rectal exam. So again, as I emphasize and I talk to my residents and I talk to my fellows, any patient presenting with constipation should absolutely have a digital rectal exam. And it's being shown that, despite our medical school knowledge and teaching, not many people really conduct a digital rectal exam in a fashion it's supposed to be. So one of the aspects involves perianal inspection to look for any soiling or any presence of any fissures or hemorrhoids or skin tags that can tell you a lot of information about what's been going on with the constipation. We should also look for any perineal sensation as well as the anocutaneous reflex. And then comes the digital palpation and maneuvers. These maneuvers are very essential to understand anosphincter function as well as the assessment of the puborectalis muscle. We often ask our patients when we do a digital rectal exams to do a push maneuver or squeeze maneuver or bearing down maneuver, which can actually helps us have a little bit of an idea about what the patient is doing while he or she is having a bowel movement. In terms of diagnostic testing, radiographs are employed. We use abdominal x-rays to assess stool burden and also as to assess for presence of fecal impaction. Contrast enema studies are widely employed to rule out any anatomical abnormalities. It is also used as a screening tool for if there's a concern for Hirschsprung's disease. Of course, it's not a very specific test. It's a sensitive test. If there is a special suspicion for Hirschsprung's disease based on the contrast enema study, we of course do a further workup to rule out Hirschsprung's disease. Additional to that, we also use abdominal x-rays to assess the colonic transit time. In patients where there is suspicion for tethered cord or spinal cord abnormalities, MRI lumbar spine should be obtained. And accordingly, if there's any patients with urinary symptoms, then of course we utilize urodynamic studies and ultrasound of the renal and the bladder system. So what are SITS marker studies? SITS marker studies are to assess the colonic transit time. And basically, it's an inexpensive and non-invasive test, which is utilized to assess the colonic transit time. Often employs ingestion of radiopaque markers, which is followed by the getting an X-ray done on the 5th day. I'm not going to go into much details. I'm going to quickly go through, but this is how a SITS marker study will help establish whether there's a presence of normal transit. So at day 5, as you can see in the first picture, it's a normal transit. There is absence of any radiopaque markers. In second slides, it's showing slow transit where the markers are present all over the colon. And in the third slide, you can see there is retention in the anal rectal area, which is more significant for either anal retention or pelvic floor dysfunction. In terms of motility testing for constipation, we use anorectal manometry testing and colonic manometry testing. Anorectal manometry testing is often used to diagnose a non-relaxing anal sphincter, which is helpful to diagnose Hirschsprung's disease. It is also helpful to evaluate defecation dynamics in children. It was also used as a tool to evaluate fecal incontinence in patients with neurogenic problems, as well as to assess the anorectal motility in children with fecal incontinence due to any anatomical or organic diseases. Colonic manometry is utilized predominantly to differentiate between functional constipation or constipation resulting due to intrinsic colonic dysmotility. It is also helpful to plan surgical intervention in selected patients with refractory constipation who have failed medical management. This is a busy slide. I'm not going to go a little bit more in details, but basically anorectal manometry testing involves placing a catheter, which has a balloon at one end, and it has sensors. And basically this anorectal manometry tests the anal sphincter functions. It also tests the rectal sensation. It also tests the neurogenic or neural reflexes, which is also helpful to differentiate between Hirschsprung's disease as well as the internal anal ectasia. With the advancement in the technologies, now we have the tools available. Traditionally, about 10 or 15 years ago, we used to have these line tracings where, the provider had to just sit and watch all these squiggly lines. Now our technology is advanced and we get what we call this is weather maps, where, we can see this red zone is basically determined by presence of like high pressure is depicted as red zone, and blue zones are the cooler zones, which is the low pressure. We also have the advancement to allow us a 3D depiction of the anal canal, which helps us, determine any sphincter laxity in any particular segment. And this is more so helpful in patients with anorectal malformation or post-Hirschsprung repair patients. In terms of colonic manometry, we have this long catheters, which is placed endoscopically into the colon. We have different kind of catheters available, but this is how a colonic manometry catheter placement looks like in a patient. This is an intense test, which often involves a 2 to 3 days time frame where a patient gets a clean out, and then second day gets a endoscopic placement of the colonic manometry catheter, and this is followed by a recovery from anesthesia and a 6-hour-long bedside testing, which assesses the different phases of colonic motility during the fasting stage, during feeding stage, as well as with the provocative challenges with medication. And how do we determine the integrity of the colonic motility? This is by looking for the presence of these high amplitude propagating contractions. As I mentioned a few slides ago, this presence of high amplitude propagating contraction is a hallmark for normal colonic motility. As we know, with conventional tracing, these are squiggly lines, but with the advancement of techniques, now we have these high resolution tracings, which are much more user-friendly and very easy to assess and analyze. So switching gears about treatment. So the goals of the treatment is to achieve a daily, soft, regular, painless bowel movements. So a child is able to continue his normal social activities with no stooling accidents, with the ultimate goal to rehabilitate colon to prevent recurrence of the stool accumulation and remain continent. Medical therapy basically involves 2 phases in a patient with constipation. Whenever I talk about constipation treatments, I always think about plumbing. So basically we have to clean the pipes. So always start with a complete evacuation of the stool, which may also involve treating fecal infection. Once the stools are completely evacuated, this has to be followed by maintenance therapy. Now, this maintenance therapy can be utilized as a medication therapy, which often involves using laxative agents, such as osmotic agents, which are stool softeners, or stimulant laxatives, which are much more robust and further helps in accumulation or evacuation of the stool. In addition to medication therapy, we often use mechanical therapies, which we're going to talk about a little bit later. So the goal of the medical therapy is, the rules. The medicine should be taken every day, same time, with scheduled sitting on the toilet, with rescue therapy if no stools for more than 48 hours, and in close communication with the care team. It is very essential to remember that the treatment has to be continued sometimes for months to years, and the slow wean of the therapy should be established once the normal bowel function is established. In addition to medical therapy, we also utilize behavioral modification, which encourages healthy toilet habits, which involves scheduled sitting on the toilet for 10 minutes, 2 to 3 times per day after eating, designing a reward system, keeping a stool diary, and I cannot overemphasize the importance of proper posture. Proper posture involves sitting on the toilet without the legs dangling, foot being adequately supported, the knees should be above the hip level, and the importance of having a knees above the levels of the hip results in a straightening the anorectal or the anorectal angle, which actually helps in propulsion. The other adjoint treatment that we use are pelvic floor physical therapy, and I'm just going to quickly go through that. We do have the ability, we are very happy to announce that we have the ability of pediatric trained pelvic floor physical therapist at our hospital, at our 3 different facilities. So we often utilize this therapy for our patients with constipation. A newer modality which has most often been practiced or utilized in adult patients is a biofeedback therapy. Biofeedback therapy is an instrument-based learning process which helps to improve bowel function. This therapy utilizes neuromuscular training to improve dysynergia and evacuation, and also it helps to strengthen the anal sphincter muscles. It also improves rectal sensory perceptions and recto-anal coordination. Biofeedback therapy in adult has been found to be superior to controlled treatment approaches such as diet and exercise, utilizing a polyethylene glycol or laxative regimen. It has also been found to be superior to standalone therapy in patients with dysynergic defecation. Not much work has been done in children with respect to utilizing biofeedback therapy. However, with minimal evidence that we have, it has shown that use of biofeedback therapy in children has been helpful for dysynergic defecation and fecal incontinence. A combined position statement from American Neurogastroenterology and Motility Society and European Society for Neurogastroenterology and Motility has recommended a biofeedback therapy for management of dysynergic defecation with level 1 and grade A evidence. So what happens when medical management fails? We know such patients that when that's where the utilization for our colorectal colleagues comes, and that's the determines like whether anything else needs to be done other than medical management. And I'm going to pass over the Kelly.
I know we need to finish up here very quickly, so I just want to pass on that. Yeah, we at the Colorectal Center do offer colorectal enema therapy, and I know it seems like an aggressive management, but it's actually quite freeing to the patient who has intractable constipation and has accidents. It's indicated for patients who have megarectum, neurogenic bowel, true non-retentive fecal incontinence, and those patients that have had a very long history of failed oral laxatives. The goal is to do a one-time enema that on a daily basis that cleans the colon out, keeps the rectum empty, and therefore avoids accidents. This we typically use a situation where we have a bag full of fluid, maybe glycerin in addition to saline, and a Foley catheter, and we can achieve the evacuation and a clean colon, and this helps the rehabilitation process. So just to finish up, the other surgical intervention that we can use on patients with these problems, we often will re-evaluate the patient under anesthesia and do even muscular assessment to make sure that, say, a post-anal rectal manometry patient or a malformation, patient is had their pull through in the proper location. We make sure that patients who have Hirschsprung's don't have any retained aganglionosis with rectal biopsies, or patients who have never been biopsied that might have Hirschsprung's. And also for patients who have anal sphincter dysfunction, sorry about the typo there, but we'll use Botox injections, and for anal achalasia patients and even patients with Hirschsprung's because of their high sphincter tone. And this will help them achieve better sphincter control, but it has to be repeated every 3 to 6 months. Finally, it's not unusual for us to get asked to place antegrade enemas in this access. And this is either an appendicectomy or a cecostomy. And we do this for patients. Now, again, less than 10% of patients perhaps that have true fecal or functional constipation will require surgery. But those patients that are sort of dependent or completely dependent on rectal enemas to maintain their therapy or to be clean, we then offer the antegrade approach. And we are also finding out, recent studies shows that the presence of neurodiverse disorders have an increased use of antegrade enema therapy and severe constipation. So it might be something that you kind of move to that a little bit quicker. So as far as surgical resection of the colon, it's very limited to patients with like significant colonic dysmotility and poor response to mechanical therapy or enemas. We will still, even patients who've had colonic manometry that shows some dysfunction, we will still try an antegrade approach typically first. But if they have a segment that just a specific segment, we can do partial colectomy. But those patients that have the most severe require a complete diversion. This is taken from a recent resource. And if you have a patient that has failure to thrive and diffuse dysmotility, sometimes diversion such as an ileostomy is required. If it's just anal sphincter problems, then Botox and biofeedback can be performed. But again, it's just very individualized. So we're going to try to wrap it up. I don't know if we have time for any cases, but maybe we can do one really quickly here just to show you some of the success. And I'll leave that to give one more time.
Okay, well, thank you. So this is a case of a boy who's a 12-year-old with long-standing constipation. And at age 4, when he failed to achieve toilet training, he was taken to a provider who told him that his constipation symptoms are likely secondary to behavioral problems. Following that, this patient has been undergoing multiple cleanouts at home and has tried various laxative regimen. And finally, the family was almost, at a wit's end as to what to do with this child with fecal incontinence. He was even seen by a child psychiatrist who thought, his anger and emotional outbursts were secondary to constipation and stooling accidents. So this is how he was when he presented to us. As you can see from this slide, the first X-ray is abdominal X-ray, which shows significantly dilated colon with stool burden. He subsequently underwent a barium enema study or a contrast enema study, which demonstrates, as you can see from St. this picture, a dilated, redundant, and capacious rectosigmoid colon. Following that, he underwent manometry studies, which involves doing anorectal manometry testing. His anorectal manometry testing demonstrated a normal sphincter function, normal rectal sensation, absence of presence of rectoanal inhibitory reflux, which is something that we employ to rule out Hirschsprung's disease. However, this anorectal manometry testing was helpful in determining that this patient actually had dyssynergic defecation pattern, which he likely developed secondary to fecal retention and prolonged constipation symptoms. Following that, he underwent colonic manometry study. As we can see, the presence of HAPCs demonstrated his colonic motility was normal. So based on the fact that his contrast enema showed a significant rectal distension, no improvement in his stooling pattern with medical management, normal colonic motility, and anorectal manometry showing dyssynergic defecation, it was decided that this patient would be an ideal candidate for a short-term rectal enema therapy. We decided, again, we don't have the norms for approximately 6 to 12 months, followed by trial of stimulant laxatives. He was started on a daily rectal enema therapy, to which he responded remarkably. At his 6 months follow-up, he was having daily soft, regular bowel movements with complete evacuation of his stools following an enema administration. And for the past 3 years, he has been accident-free.
And so it's not unusual for us to graduate patients off the enemas, just like if we even put a cecostomy in, like a person who has a gastrostomy tube, you can actually get rid of it when they're eating better. We can do the same when patients are stooling better, that we don't have to maintain that forever. And at this point, we can graduate patients to laxatives and then ultimately even off medications. So I'm just going to proceed here to the final, just to close this up, is that essentially, our Children's Colorectal Center serves multiple people, some across the country, but mostly in the Western Pennsylvania area. And we have over 700 plus visits a year to encounters. And we actually field a lot of questions, and it's that give and take that really matter. And roughly 200 portal messages a month at least, and roughly 8 to 12 patient phone calls a day. We hold 1 to 2 bowel management workshops a month, and also patient-centered events. We're participating in the Pediatric Colorectal and Pelvic Learning Consortium, which we're one of 16 centers in the country that let us gather real-time data and patient-related outcomes studies. So we can actually study that, which is really shows our dedication to this problem. And then finally, we actually participate in the Pull-Through Network, which is a nonprofit self-help organization for patients and their families, and they have ultimately a conference once a summer and a camp. And this year we started our first annual patient-centered event at the zoo we hosted roughly 250 patients and their families for a free time and a picnic at the zoo on a day in June, and that was very successful. But bottom line is, our key to the successful bowel management program is just the consistency and the dedication of both the team and the family. The family's clear expectations and goals, and this is partially achieved by good understanding of the pathophysiology, which we achieved with our bowel management workshop seminar, and then extremely close follow-up, our multidisciplinary approach, our dedication to research, and the resources that we have. And so I'd just like to thank you for your time. I'm so sorry for the delay and that this dragged on, but thank you for your attention. And I guess we can stay on for any questions that people have.